Hello everybody. Today we will be briefly discussing about the upper third of the facial fractures, which would comprise of frontal bone fractures, nasoethmoidal fractures and skull base fractures. For a maxillofacial surgeon, this area is quite critical, and this is one area where you need a team approach with the neurosurgeons, with the ENT surgeons to manage fractures of this upper third face. Why is that important? Because it is surrounded by cavities which are vital in their functions. The cranial cavity holds the brain, orbital cavity holds the eyes or the globe, and the nasal cavity which has olfactory organs in it. So any trauma or fracture in this area would compromise these vital organs and may have severe complications and morbidities. The incidence of upper third facial fractures has increased in the last few decades. The reason for that is high velocity road traffic accidents because of increased number of vehicles on the road and not wearing helmet on two-wheelers. So now we see more facial fractures or more upper third or middle facial fractures because of these reasons. So we'll start with the frontal bone fractures first, and then we'll proceed to nasoethmoidal and skull base fractures. Now the frontal bone fracture, as you remember, has two tables, the inner or the anterior table and the posterior table. Between these two tables lies the frontal sinus, which is lined by the sinus mucosa. The frontonasal duct opens in the frontal sinus and also in the nasal cavity, where it drains the content of the sinus into the nasal cavity. So whenever there is a fracture of the frontal bone, we can have a fracture of the anterior table, the posterior table, involvement of the frontonasal duct, all the three components seen in together. So coming to the anterior table fracture, which has less complications and less morbidity. The anterior table fracture are the most common of the frontal bone fractures. It can be undisplaced, minimally displaced or depressed. Whenever there is a fracture, this displacement, the bone goes inside because of the empty cavity there. So for an undisplaced fracture or a minimally displaced fracture, which is not going to bother the aesthetics later on, one should avoid opening these fractures and fixing it. If there is a clinically detectable depression and it is seen in the CT scan also, in that case we need to reduce the fracture bones, elevate it from their depressed position and then fix it with mini plates or steel wires. The incision, most of the time there is a laceration on the forehead, and we should try to go through these lacerations and fix the frontal bone fractures. If the laceration is small or insufficient, then we have to go through the bicoronal approach as seen in the pictures shown in the text. Now, if there is a posterior table fracture, most of the time the posterior table is there in addition to the anterior table, right? Now again, if the posterior table is undisplaced or minimally displaced, one should avoid opening it because of the simple reason that behind the posterior table there lies the frontal lobe of the brain, which can have complications. So the posterior table fractures, if displaced or need management, we have two approaches to fix the posterior table of the frontal bone. The first one is called as cranialization of the frontal sinus. What do we do here? We open the cranial cavity through the bicoronal incision and we remove the posterior table completely. We remove the sinus lining and we block the frontonasal duct opening. So what we have done is we have removed the sinus and now the brain lies in contact with the anterior table. We have increased the volume of the cranial cavity. There is no posterior table, the sinus has gone, the brain rests at the anterior table. This causes cranialization of the frontal sinus. This is a more definitive way of treating posterior table fractures in the frontal sinus and have less complications and less morbidities. Compared to the just mentioned approach, the other approach is obliteration of the frontal sinus fractures. What do? We fix the posterior table, we fix the anterior table and we obliterate the sinus with autogenous tissues like fat, muscles or bone, or with alloplastic bony materials. So we have obliterated the sinus and blocked the frontonasal duct opening. This procedure has has certain amount of complications like graft rejection or infection. Then hence slowly it has been out of the practice in the last 1 decade. Now for a posterior tibia fracture, cranialization of the frontal sinus is the better way to treat it, right? This takes care of the frontal bone fractures, the anterior and the posterior tibial fractures. Now we come to the nasoethmoidal fractures. Ethmoid bone is such a bone which is hardly seen by us clinically, and it is lying somewhere deep behind the nose, nasal architecture, and we never in our life are going to see it or visualize it. But it is very important because of the relationship this ethmoid bone has with the cranial cavity, the orbits, and the nasal cavity. It extends into the cranial cavity in form of cribriform plate, which has olfactory nerves going through it. So any fracture in that area would lead to anosmia or loss of smell. Any fracture in the medial wall of orbit, the orbital volume would increase and there would be a sunken in or inophthalmos of that particular eye. So ethmoid bone, again, if there's a classification for ethmoid bone fractures given by Markowitz, which is clinically applicable and very easy to use in the clinical practice. Type 1 Markowitz NOE fracture is where there is a single piece of NOE segment with a large chunk and the medial canthus is attached to it. It can be very easily fixed, reduced and fixed either by extraoral or intraoral approaches. Second Markowitz type 2 is when there is more than one piece is there, but the medial canthus is still attached to a bony piece which can be reduced and fixed to the superior and the inferior bones. Again, this can be approached through the bicoronal incision or through intraorally. Type 3 is where there is a combination type of fracture of the NOE architecture. They are very small pieces and the medial canthus has detached. This is the most severe kind of fracture with high morbidity and very disturbing aesthetic appearance. There is flattening of the dorsum of the nose. The distance between the eyes has increased, which we call telecanthus, and there is inophthalmos. So these fractures, the most important point to be taken in NOE fractures is the attachment of the medial canthus to the nasal bone. If the attachment is intact, most of the time the surgery is very easy. Most of the complications is because of the detachment or wrong placements of the medial canthus ligament to the nasal bone. Now Markowitz has given a classification which is very easy to apply in the clinical setup, and it is based on the attachment of the medial canthus to the bone. Type 1 Markowitz is where a single piece of bone is fractured, both superiorly and inferiorly, and the canthus is attached to that particular big piece of nasal bone, right? So it's very easy to manage these cases either conservatively, manual reduction and with a nasal splint, or if we have to reduce it, we can approach the inferior fracture with the intraoral approach and the superior fracture through a small lunge incision or a coronal incision. So that is type 1, which is the most easiest and gives you the best result. Now type 2 is when there are multiple pieces of the bone, but the size of the pieces are such that they can be reduced and fixed with mini or microplating systems, and the canthus is still attached to one of those pieces. So both in type 1 and type 2, the medial canthus is attached to a particular piece which can be fixed, reduced and fixed. So type 2, again, we can go through the coronal approach to approach the superior fracture, and intraorally to fix the piriform rim and up to the nasal fracture. Type 3 is the most severe type of fracture with this comminution and detachment of the NOE medial canthus ligament, and the pieces are so small that we cannot reduce them or fix them. In that case, we have to do a bone grafting, a camouflage surgery. We have to build the nasal dorsal projection and reduce or correct the distance of the in between the eyes. So we have to correct the telecanthus, traumatic telecanthus. Both of these require high skill, and a lot of surgeons have different ways to do it. A lot of people do a cranial bone graft here to fix the dorsum of the nose and pass the wires through the medial canthus and fix the needle canter through that particular bone graft. Whatever we try, type 3 Markovitch is very difficult to treat in the clinical setup and always has a residual effect later on. So this was about nasoethmoidal fractures. Lastly, we have skull-based fractures. Now, skull-based fractures, as we all know, is part of a head injury component, right? So, role of maxillofacial surgeon is less in case of skull-based fractures. It is more of a neurosurgeon and ENT colleagues who have to deal with these fractures. Our role is to identify these fractures, right? Any sign and symptom of head injury, unconsciousness, episodes of vomiting, CSF leak through the nose or the ear may warrant us to have a CT scan where we can look for a skull-based fracture, take an opinion from our neurosurgeons or ENT surgeons, and then the fracture can be treated. Most of the fractures of the skull base are treated now with endoscopic approach via the maxillary sinus or the nasal cavity. And any fracture in the skull base can be sealed with fibrin glues or with various autogenous tissues like abdominal fat or fascia lata. So this was a brief description of frontal bone fracture, NOE fractures and skull base fractures. Post-op complications in upper third facial fractures are high. Persistent headache, chronic headache because of mucocele or infection of the frontal sinus, CSF leak, diplopia because of the disturbance of the orbital visual axis, anosmia, loss of smell, which is almost permanent, could be the potential complications which you may encounter in your patients, and to deal with them accordingly. There has been massive advancements in the management of upper face fractures. Intraoperative navigation, intraoperative CT scans have reduced the burden of clinical judgment on the OT table. You can reduce a bone, see it immediately on the screen with an intraop navigation or a CT scan, and then you can change the position and refix it if you think it is wrong. Similarly, various bioresorbable plating fixation systems are there, where when you don't want to use a metal in that paper thin bony areas, where we can use bioresorbable plating. In the last, I would say that upper face fracture is something where you need a team approach. You can't do it alone. You have to have a neurosurgeon and ENT colleagues whose opinion matter in upper third facial fractures.